Stanford University.
Well, good evening, everyone. Great to see you here again tonight. Just one apology. Unfortunately, as much for me, I will miss next week's presentation because I'm on my way to Brazil, so I couldn't quite figure it. Sounds like it's going to be fun, but I'm just going to be there for a day and a half. So there you go. And it won't, I doubt I'll be outdoors even for 2 minutes of that time. But anyhow, tonight we're going to move away from some of the themes that we focused on in the past to have an interesting tour of a topic that doesn't get enough attention, and that's the issues of sex and gender and how they influence health and disease. Now, we talked a lot about aging last week, which was interesting in its own right, and we haven't talked about the impact that gender plays on aging, but you know, on aging, but you know that there is an impact because those of you who harbor the Y chromosome, which parenthetically is shrinking over time, not to frighten you, but forget about your testosterone in the long run, is a factor that actually doesn't subscribe to longevity as much as having two X chromosomes. So there are differences in many features of life and health that are important, and a champion investigator for this over literally decades of time is our speaker tonight, Marcia Stefanick, who I have had the privilege of both listening to and learning from during the time that I've been here. And she has been the kind of investigator whose work has literally made headlines. For some time now, she has been a lead investigator in the Women's Health Initiative. And for those of you who've followed the press and paid attention to the changing recommendations that have occurred with regard to things like hormones, diet, exercise, impact on one gender or another, she has been the lead person for these contributions. The second reason why I was very eager to have her present tonight is because we've talked a lot about individual areas of health initiative and research that is sometimes at the laboratory level, but we haven't sprung up to the area of population-based research. So the kind of work that she's going to be contributing to in the discussion tonight is the area that we're paying increased amounts of attention to, and that's the realm of population science. Now, Marcia has a long legacy that led her to this place, which started, like almost everybody else, it seems to me, on the East Coast. She was north of Boston in Pennsylvania at the University of Pennsylvania, and south. See, when you're from Boston, you don't think, but it's true. She was south of Boston, I guess south of the Charles River, as they say, and did her undergraduate work at Penn, and then came to Stanford where she did her doctoral work, and she has been on the faculty in the Stanford Center for Prevention, which has been a lead organization in the Department of Medicine, leading to many of the initiatives that I've already described. So I'm really pleased to have a real icon, Marcia Stefanick, speak for us tonight. Marcia.
Thank you, Phil. I don't know about the icon part. So I'll say that I come from a large family with 4 brothers and 2 sisters, and so sex differences is something that always interested me. Like, why are they different from me and my sisters? So I would like to start with obvious sex differences. I think most of us would immediately know a man from a woman, but you may not realize that when we talk about the most sexually dimorphic bone in the body, it's the pelvis. And this interests me a lot. I do work in bone research to try and understand what it is about the genes that will turn a bone into a male pelvis so that you actually have the maximal locomotion skills versus a female pelvis, so you can get a head out through that opening. And lots of women have died because they couldn't get a head out through that opening, and lots of women are still dying. So these are very important pressures, these two forces acting on this one bone. And it interests me a lot to try and understand why do sex differences affect all of these genes and all of the traits that we're going to be talking about tonight. Once you've got a different pelvis, you've got a different leg structure. Basically, you're going to have a very different angle coming down from that pelvis if you have wide hips, and you're not going to run quite as fast, and you're not going to be quite as capable in certain kinds of things as someone who's got really narrow hips and doesn't have to come down that way. And if you start to look at the elite running female runners, they have narrow hips relative to wider hipped women. So we have a lot of dimorphism even within each of the sexes. The other thing that's going to happen then is once you've got a different kind of angle coming onto the knee, you have a different knee structure. And we do have the case that we have certain kinds of injuries that women experience much more than men do because of our biomechanics. So we could do a whole talk on biomechanics, but we don't have time. On the other side of the coin is the rib cage. If you've ever noticed, men have barrel-shaped ribs. If you do yoga, you know that they breathe with their diaphragm. Women actually have kind of bucket handle ribs. We breathe differently until we get into our 8th or 9th month of pregnancy. When life gets really hard, you can't get that diaphragm pushed down anymore, and you start to really appreciate why you would end up with a different kind of rib structure. And women will start to complain that their ribs really hurt in that 8th or 9th month. But this is another case where, to some extent, it's our reproductive function that has really created these different kinds of bone structures. Once you've got that kind of a rib, and actually to some extent it relates to the collarbone, you're going to have a really different shoulder girdle as well. Once we start to put the muscle onto this, we're going to have a different way of throwing. But there are so many reasons that men and women are different when we talk about sports. And when you look within each sport, you're going to see that the women who are excelling in things that normally would be a male skeleton have skeletons that are a little bit more in that direction. These are distributions that vary dramatically across each sport, each ethnic group. We have lots of variety, but we end up with a male and a female prototype. So we have very well-known differences in bone mass. Men have thicker bones. We're going to talk about that a bit. Greater muscle mass, lower % body fat. These are very much affected by the sex hormones, and this has been my interest for a long time. There's also, I think last week you probably would have heard, more intra-abdominal fat. You should know that the intra-abdominal fat is actually physiologically very different from subcutaneous fat. Those of you women who hate your thighs and your hips, that fat is not easily released. The lipolysis factors for that fat is very different physiologically from the intra-abdominal fat. The good news for women is that that fat is also fairly safe. You're not going to release it just with stress. Whereas if you have a lot of intra-abdominal fat, that goes right into the portal circulation, right into the liver, and starts to wreak all kinds of havoc on proteins that relate to your cholesterol profile and your blood clotting factors. So there's lots of interesting issues about that, and we'll come back to that as well. Now, what's less appreciated is how different all the other organs are, other than size. So it's true that a smaller person will have a smaller heart, and so on and so forth, but there's actually structural differences in the brain. The brains are really quite different. There's some great research going on here at Stanford on those issues, but each of the other systems do have sex differences that are not fully appreciated, certainly not brought into a lot of the medical education, and so you're lucky in your mini medical course that you're going to get a little bit of it. What I'm going to do is I'm going to start with your sex determination. Recognize that the chromosomes is kind of the key. We all think about the X as a female and the XY as a male. On the Y chromosome, there is a special region called the sex determining region of the short arm of the Y chromosome. And about 6 to 8 weeks of gestation, it starts to direct a protein that's going to bind to DNA, and then it's going to change the cells that are in the genital ridge and eventually turn an indifferent gonad into a testes. I'm going to show you that in a moment. But what's really interesting is that we've been following this story long enough now that we're aware that there are other places And some of the autosomes, which are not the sex chromosomes, there are genes that can actually play a role in how the testes differentiates. And also on the short arm of the X, there's a particular gene. And so we keep learning about these new genes, and I'll tell you the way that we've learned about it is by infertility clinics. It turns out that in Sweden, any case of infertility gets worked up genetically, and they start to really try and understand what is it about this particular person that may be why they ended up being a different sex from what we expect. So if we have an XX male, we don't expect that, or an XY female. And they've actually done all of these studies to try and sort this out. Now, when we talk about the X chromosome, the one thing to realize is that it has nearly 1,100 genes compared to the Y chromosome, which has less than 80 genes. So they're very different in terms of these genes. Most of the X chromosome, if you have two X's, most of the second one gets inactivated, or it's actually kind of a random way that this happens. But some of them actually escape inactivation, and that plays a role in some of the sex differences that we'll be talking about. When we talk about recombination, you actually can have recombination. So I think you probably had some genetics and you know how the strands pair up. Well, on the short arm of the X and the Y, they do have some of this recombination, and also genes on the Y chromosome. Well, the other point to make is that the genes on the Y chromosome have about twice the mutation rate as those on the X. Question?
What do you mean by the short arm of the X?
When we look at the X chromosome, if there were two X's, you'd really see this, but there's a short arm and a long arm of this chromosome. So the short arm is analogous to essentially the short arm, and here's the sexually dimorphic. This is a schematic, so it's not very true to life, but there's also housekeeping genes that are on these chromosomes that take care of the whole chromosome just to keep it intact. Okay, so as I mentioned, there's an inactivation that occurs. So we don't actually have two active X's. There is an inactivation of one of the X's. And this happens really early on. It's thought to happen at the 20 cell stage of the blastocyst. But not all of the second X is inactivated. About 15% of the genes on the inactive X escape. And not all of these escape genes are on the Y. Not all escape genes are on the Y. So we have escape genes that are on these X's. 10% are partially inactivated. So we basically have a lot of places that we can get sex differences because of how these particular chromosomes function. And in fact, there's a really interesting book called Females Are Mosaics. And to just give you some sense, identical twin girls are not as identical twin boys. And that's because in the case of the girls, they can have this random inactivation, and so they may have very different sets of what was inactivated and activated, whereas for the boys, they just have one X and that doesn't get inactivated. The other issue to notice about sex differences is X-linked recessive mutations. And actually in infertility technology, they have the means to examine the embryos to see is there an X-linked problem on one of them, and they can basically decide that that's not one that we're going to implant. So this is a strategy that some people actually use to be sure that they don't end up with these X-linked genes. Most of us just go along with what we're going to get. This is going to cause color blindness in males at a much higher rate, and a number of other issues that are, again, sex differences arising from these chromosomes. Now, I'll just mention that the fetal testes doesn't actually start to secrete testosterone until about 8 to 10 weeks. But what's important about that is that the fetal testes does secrete testosterone, and that's going to become important as we proceed. What I'd like to do is say just a little bit of embryology and to recognize that in the beginning, we are indifferent. We're not male and female. We have an X and an XY. Those chromosomes may or may not act like XYs, as we just said, depending on what's going on with the other genes in the whole chromosome set. But we can start with a bipotential gonad, and a really interesting issue is that the germ cells come from a totally different place. They migrate through the embryo and they find where that gonad is going to be. And depending on what happens by the time they get there, they're either going to become sperm or eggs. And so we basically have a very interesting potential to be male or female. If we then take the next, and this is at the 5-week stage that the germ cells start their migration, When we move on into the indifferent stage for the internal genitalia, about 7 weeks, we have 2 complete sets of ducts. We basically could become hermaphrodites if both of these systems would completely develop, but we basically have a mesonephric duct system that becomes the Wolffian ducts. Those will evolve into the epididymis, vas deferens, and seminal vesicles if there's testosterone present. Now, you don't need estrogen because you're in a pregnant woman who's just bathed in estrogen. So what you need is you need another hormone to get in there and basically say, hey, there's something else going on here. And that testosterone is going to come from the fetal gonad. The paramesonephric ducts become the Müllerian ducts. These, left on their own, would become a uterus, fallopian tubes, and the vagina, but the fetal testes secretes not only testosterone, but a protein called anti-Müllerian hormone that suppresses the Müllerian ducts. And so as long as you're secreting that protein, you'll get rid of the Müllerian ducts, so you won't be a female in terms of those organs. And as long as you have testosterone, you're going to end up with the male ducts. And so again, without testosterone, the Wolffian ducts disappear. Without the anti-Müllerian hormone, the Müllerian ducts disappear. So we're going to end up with 1 set of ducts depending on whether we have testosterone, and the AMH will be a male. We'll have male genitalia. It's a little hard to say what we will actually be for other reasons. And if we don't have testosterone or AMH, we'll have the female organs. Now that said, another thing that I think is really interesting about all of this, and just to kind of think through the fact that if all of this is programmed in to end up with these very dimorphic organs, genitalia, what else is going on in the whole body? And we haven't even begun to touch into all of the other things that we should be studying. And I will just do a quick sales job and let you know, June 11th, we're having a very special symposium here at Stanford on Beyond X and Y. It's a basic science, clinical science grouping where we're going to really go through, and it's all the institutes of medicine are involved in this, so that we're going to be looking at all of these issues from a very basic scientific perspective to see what are the clinical relevance. But one that I can just quickly mention is not only do we have to make a testes, but the testes starts out, the indifferent gonad starts up in the abdominal cavity, just like the ovaries where they're going to end up. But the testes has to migrate out from that spot, make it through the abdominal wall, and you all know about inguinal hernias, which is because you have basically made your way out of the abdominal organ, down underneath the skin into the scrotal, what will become the scrotal sac, and that's where you're going to end up if all goes well. Now, if all doesn't go well and you end up with an undescended testes, you have a clinical problem, potentially infertility, and this is something that sometimes this can be reversed with hormonal treatment at the time of puberty, but this is one of the clinical issues that could happen. And then the other one that I just mentioned is the inguinal hernia, where you essentially have a place that you could have a little opening and some of the intestines could come out into that opening and cause a lot of pain. Women can actually have umbilical hernias. There are other places you can have hernias, but the one that we hear the most about is this inguinal hernia. So the point on this one is you can see where this is emerging and making its way through as it migrates down into where it's going to take up residence as an adult. So again, these indifferent internal genitalia will turn into a male set and a female set of the genitalia. And we don't have time to go into more detail. The other thing that we have to change is the external genitalia. So again, we have an indifferent stage, about 8 weeks. You really can't tell the difference between a male and a female at 8 weeks. And if you have enough androgen on board, and this can be coming from the fetal testes, but it can come from other things. If a female is exposed to testosterone in utero or in pregnancy, this can happen. There are also hormones that can be released from the adrenal gland that will be androgens. Androgenic can be converted to more androgenic components. So you can actually end up with a masculinization of what would have otherwise been a female. The most potent androgen is dihydrotestosterone. This is coming from testosterone in the skin and genital tissue. There's a special enzyme, and I can tell you if you don't have that enzyme, you're not going to be able to look as male. And I'll quickly tell you that one of the interesting things that occurred during my, I guess I'll give away my age if I say this, but when I was studying as a graduate student, there was the finding that there's this whole group of people that have a genetic, there's a lot in this community that have particular genetic mutation that they basically do not make 5-alpha reductase, and so they are born looking like girls. And when they go through puberty, because testosterone is so high at puberty, they actually then have enough testosterone to change the situation, and they essentially start to develop a penis, and they start to look much more like males. And in these cultures, they actually have words for this, penis at 12, and known locally as machi hembras. I don't know if I said it right, anyone who knows Spanish could say, which is first woman, then male, and the whole community celebrates these people. They recognize that we have 3 kinds of sexes. We have a male that will stay a male, a female that will stay a female, and then we have a female that's going to become a male. And so we have some very interesting issues there. As I pointed out, more differentiation will occur at the time of puberty, and this is basically directly from testosterone that will induce the growth of the penis, and then DHT will cause more changes in the prostate. This is really just kind of showing you the differences between becoming a male and becoming a female. And another important issue is the labia will actually fuse in the male so that we end up with a scrotum, and they'll stay open in the female. And I won't go through all the other details there. Another area that changes before you're born, so all of that's before you're born, is the hypothalamic pituitary gonadotrope and gonadal axis. Essentially, we're going to be regulating how these hormones are produced from a signal from the brain that's going to go to the pituitary, that's eventually going to release a hormone that's going to go to the gonads and either stimulate testosterone or estrogen, as the case may be. Now, it actually turns out that all of that happens in utero. There is a huge surge of testosterone somewhere about the 8 weeks period in utero. And so a lot of changes happen in the brain in 8 weeks of gestation. And some of those changes will continue on through. But an interesting issue is that in early infancy, within a few minutes of birth, their LH has this big surge, about a 10-fold increase in males that doesn't happen in females. It's a short-lived surge, but for about the first 3 hours after birth of a boy, there is this big surge, which then means there's a testosterone peak, and this goes on for about 12 hours. So these are things that people aren't aware of because you're paying attention to lots of other issues, but something to just realize is how much is happening before we're even paying attention to being a girl and a boy. So again, the first few days after birth, follicle-stimulating hormone, which is going to eventually stimulate the ovary to produce follicles that will eventually ovulate with luteinizing hormone signal. And luteinizing hormone, which is the main regulation of the testes axis, exhibit a pulsatile pattern that have wide perturbations for several months. So there's a lot going on that we haven't studied very well. And these are areas that I think are fascinating and certainly deserve a lot more attention. These LH pulses are much higher in males than in females, so all this is happening in your infant baby. Now, this high gonadotropin that happens in infancy is associated with a transient second wave of differentiation of the Leydig cells in the testes, so that we end up with this increased testosterone for about 6 months in males. And we do get some increased estradiol for about 2 years in females. So all that's going on, and you're not even paying attention. You're all saying, oh, my boy looks different from my girl, and then we're going through our feminist phase. No, they're all the same, but in fact, they're different, and that doesn't mean, that means they're equal but different, if you would like to say that. Or maybe you don't want to say equal, whatever you want to say. At any rate, when we start to talk about the fundamental differences in the reproductive system, in the case of men, they're always reproductively capable. Well, I shouldn't say always, but from puberty until somewhere in old age and maybe on. For women, it actually turns out that we're really only fertile for 12 hours of a month. So you can imagine, how do you get all those pregnancies with only 12 hours per month? But nonetheless. When we talk about germ cells, in the case of the males, they actually have the ability to continue to make new sperm over the course of their reproductive life. Whereas for females, we're born with a certain number of eggs, and we basically use up every month that you ovulate. You're not just ovulating one egg, you've got the whole set of follicles that are basically giving off eggs. And at some point, the average age is about 50, you essentially have depleted most of your eggs. That said, I can tell you back when I used to do rodent research, we were aware of the fact that if you put an old ovary in a young female rat, that ovary would start to be able to ovulate again. And if you put a young ovary in an old rat, it would become anestrous. So it isn't just the ovary. There's definitely brain aging that's part of this whole system. In terms of the endocrine pattern for males, it's pretty much well regulated. So as LH goes up, testosterone goes down. As testosterone goes up, LH goes down. And they just go back and forth, trying to keep it pretty equal. Whereas for females, we have this very cyclic pattern. All of you the women have known about your menstrual cycles. The control for males is completely hypothalamic. In the case of females, we also have the corpus luteum that is essentially the byproduct of once the ovary sheds this or ovulates, there are cells that actually start to give off progesterone and will facilitate the way this whole cycle works. And we have a positive and a negative feedback in females. And that, I'm not going to go into the detail of that, but the point I want to make is they're very different. And this is something that, again, differentiates men and women. Now, as I mentioned, in most animals, we have this exposure to fetal or infant brain to the sex hormones. And in most animals, these cause irreversible changes. Now, most of this work, I can be honest with you, has been done in zebra finches, so we know they sing very differently if it's a male versus a female. And some other animals, when we start to look at the adult reproductive behavior, animal sex behavior is very, very different. And most of the time when people talk about differences in behavior, they start to talk about sex behavior as opposed to a much broader definition of what might be a behavioral difference between men and women. So the sex hormone levels differ, as we mentioned. We have specific sex-specific genes that aren't dependent on sex hormones that may, in fact, affect human brains. There is, as I mentioned, work going on here at Stanford looking at this. You can actually start to see differences between the brains by age 2. And when we start to talk about adult brains, they really are different. There's a different size. I'm not going to say who's larger, but I guess I will. It is the case that male brains are larger, and it's not just because they're larger. But that doesn't mean anything. You could have a lot of, who knows what that means. We know the size and the shape of the corpus callosum are different. Certain of the hypothalamic nuclei are different, including nuclei that relate to temperature control, which is something that's also quite different between men and women, especially when we get into menopause and things like that. And the gonadotropin feedback response to estradiol, as I mentioned, is different. Whoops, I didn't mean to go. Oops, sorry, I have to get back. Question, yes?
When you say larger, does the male brain have more neurons, or are you just saying physically larger?
The volume is larger, and there's actually differences between gray matter and white matter. And I'm going to get it really messed up if I try to remember which is which. But one sex has more gray matter, one sex has more white matter. And we don't really have good functional distinctions about what that means. Some of that work is being done by Alan Reese here in the psychiatry department. He's got some really interesting fMRI data too, where you can actually look at the functional changes. Humor is an area that he's done a lot of work on, so I won't go into that because it's a small enough study that I think we didn't get enough kinds of humor to know what to do with it. At any rate, when we talk about this, I'm going to just tell you a few anomalies to this whole system to realize that you can have chromosome Disorders, I'm using the word disorder. If any of you have these, I don't mean to be offensive. Basically, it's because we have an idea of what the norm is, and it doesn't mean that anybody's really disordered. But at any rate, two that really are not uncommon is Turner syndrome and Klinefelter syndrome. The Turner syndrome is one X and the other X isn't there. This happens in about 1 in 2,000 female births, which is why I think it's not that uncommon. These girls will have normal female genitalia. Their internal anatomy isn't developed, so this is the proof that we do need two X's. We don't get a functional ovary without having that second X. So they have no breast development, no menstruation, and they're not fertile. They also have a lot of other health problems that come on down the road. And I won't take you through all of those, but well, heart, kidney, thyroid, they have other problems. The other one is the male, XXY, so two X's plus a Y. As long as you have a Y, unless you have one of these bizarre genes on one of the autosomes that can override it, and it's very, very rare that that happens. As long as you have a Y, you can have XXXXXY, as long as you have that short, that sex-determining region of the short arm of the Y, you will become a male. This happens in 1 in 500 births, again, not uncommon. These males will have an undersized penis and testes. They're typically sterile. They have a low interest in sex. They're somewhat feminized in their female characteristics. So you can see on this example, they're showing some breast development, some wider hips. If desired, you can actually do testosterone treatment to get some more masculine traits with this particular individual. Another set of disorders that can affect the prenatal hormone process are androgen insensitivity, fetally andronized female, and DHT deficient male. The DHT deficient male is the one I already talked about. This is really a 5-alpha reductase problem, so that's the guavadoces or the machim, I forget how you say it. But to show you the androgen insensitivity syndrome, this is a really interesting situation in which it's a normal, the chromosomes are normal, XY. The males are insensitive to testosterone. So they have an androgen receptor that just doesn't respond to testosterone. This can be complete or partial, but essentially they develop a female external genitalia, but with a shallow vagina. And they often just are raised like normal girls, but they never start their menstrual cycles. And that's when the gynecological examination will occur.
Marcia, wasn't the 5-alpha reductase the part of the anomaly in the Pulitzer Prize winning novel Middlesex?
I think it is. So what Phyllis says, wasn't that the reason that the person had it in Middlesex? But I didn't actually read it, so I can't say for sure. Okay, it's a great book. Won the Pulitzer Prize. I thought it was the adrenal androgen story, but I'm not sure. We'll talk about that one in a minute. At any rate, it is a good book, so we've got the book review now. Okay, so this may not be discovered, and essentially this person, because they have a normal testes, a normal fetal testes, that produce that testosterone, but also the anti-Müllerian inhibiting factor or the anti-Müllerian hormone, have none of the female ducts. So they don't have any of those organs. So they have no ovaries or uterus because they never had the Müllerian factor. And so they really have, it's a shallow vagina, but there's nothing else there. And actually, there are some famous people who have this syndrome that you think are beautiful women, and I'm not going to say who they are because that was released, unfortunately, before we had HIPAA. But there is a very famous actress who everyone thinks is a female, but is actually, well, it is a female. This is gender, so we'll get to what gender is relative to sex. So the fetally androgenized female is what I thought was in the Middlesex case, but maybe Phil's looking it up now.
It is.
Oh. It's this one? Yeah. Okay, so the fetally androgenized female is a chromosomally normal female, XX, but for some reason she's been exposed to too much androgen. And this can happen because the adrenal gland may give off a lot of an androgenic or testosterone-like hormone, And so this is the most common case, but there also were certain drugs that women were exposed to that were preventing miscarriages that also caused this particular problem. So what happens is, because of the testosterone, the female has external genitalia that look very much like males. So they come out with an enlarged clitoris that might look like a penis. The labia are fused that resemble a scrotum. Now I can tell you, I put this in yellow because there actually was a Secretary of Health who opposed this practice of immediately doing surgery on these females, and this is called intersex. We talk about an intersex group. There's actually a very active group now in Holland, or in the Netherlands, and in certain areas in the US that are basically saying, let me just figure it out myself. Don't do this surgery and turn me into another sex. So it's a very controversial topic, and one that I want you to think about. If you were the parent and the doctor says, it's a, and you don't know, and then you find out that XX is this and this is like that, but this person's now going to have surgery the day they're born so that they will look a certain way, but will that surgery really be good? Will they be able to hold up and grow? So these are very controversial issues that I think bear some ethical discussion. But at any rate, it has been reported that these girls may in fact have some androgenization of their brain, but then that's also a big debate. Do we really have such a thing? So there's a lot of debates in this, and I know somebody was eager to hear what about emotions, and I'm not going there tonight. I do want to know about crying, though. I keep trying to figure out what's the physiology of crying, and it's my experience that older men start to cry too. Is that your experience? I could be wrong. I didn't mean to look at you. I meant everybody. So it's an area of aging I think we should study. I think it'd be really fascinating. At any rate, something that's very interesting to me also is the fact that we're born, we have all this stuff going on, and then we just kind of go into quiescence, and we go into what's called the juvenile pause, and the hypothalamic pituitary gonadal axis just kind of shuts down. It was active, as we said, 6 to 8 months in boys, 2 to 3 years in girls, and then it just kind of waits until puberty. And what signals that onset of puberty is another very interesting topic that I don't have time to go into. But at any rate, two major differences between males and females is the age at which it begins. So for girls, it's about usually 2 years earlier than boys. It's horrible if you're a twin and you're the boy, because there's your sister sprouting up. And I had twin brothers and sisters, so I got to watch that. But at any rate, for girls, we are dealing with the fact that it seems to be getting earlier, younger, our puberty now. This may be because girls are obese, and it may be an obesity-related phenomenon that you probably heard about last week. But at any rate, because there was a longer period of time of exposure to estrogen, girls' bones have been a little bit more mature than boys' bones, and they start to take off a little bit sooner. And they actually sprout up, and I'll show you this in the next slide. They sprout up and they basically reach their reproductive maturity about 4 years earlier. So most girls are as tall as they're going to be about age 12. There's a lot of variation on that. If you haven't started your menstrual cycle and you keep growing, you actually will be taller if you have a late menses. So we'll talk about that in a minute. Boys are growing slowly over that period before they have their big surge. And then, of course, the other big difference is the hormones. It's not the case that girls have estrogen and boys have testosterone. We both have both hormones, but there's a lot more estrogen in the girls and there's a lot more testosterone in the boys. And I won't show you all of that. But when we talk about the growth spurt, here you see girls taking off this doesn't mean they're still growing, but they really accelerate and then they start to slow off. Boys are about 2 years later, and then they go up even higher and go off. Now what I stuck up here was just to show you that the estrogen is affecting, and it's actually estrogen for both boys and girls that affects the bone. We used to think it was testosterone, but now we know that it's really estrogen. Testosterone's converted to estrogens. So it will affect the cartilage, which is kind of the fetal bone, and then eventually you develop real bone cells. But where the growth is occurring is at these ends between the shaft, called the diaphysis, and the ends of the bone called the epiphysis, there's this growth plate, this cartilaginous growth plate. And the shaft grows tall, starts to just get taller, longer and longer. But as soon as you fuse those growth plates, that's as tall as you're going to be. And when they actually do the radiographic measurements to see if your daughter or your son is at their adult height, they're looking to see, are those bone plates fused? So that's the place where the growth is occurring. If you're growing longer, later, if you don't have your puberty as soon, you're going to be able to get more growth before those things fuse. And so that's an important difference. There's lots of other secondary sex characteristics that we talk about. So we've already talked about stature, wider hips. We've already talked about, we haven't talked really about the heavier skull and the bone structure, broader shoulders in boys, chest wider than the hips, larger hands and feet. Hair, I'm going to talk a bit about hair as we move on, so we'll get back to that. I think most of these you know: voice, skin texture, breasts, fat, where we put the fat, and a waist-hip ratio, which plays a role in your risk for heart disease, and we'll get to that in a moment too. Now we talk about Tanner staging in boys. The first thing where you really say that they've gone through the first sign of male puberty is testicular volume, and they actually measure this volume by different stages. So we talk about pubertal hair, and we talk about the length of the penis, and axillary hair, underarm hair. And girls, when we get to breast 2 buds, then we start to say this is the first sign of puberty in girls. But we go through these Tanner stages that's important for pediatricians, and there's actually some very interesting work done on how Tanner stage relates to age, and it's really Tanner stage has a lot of the is associated with a lot of the psychological issues much more strongly than age is in young children. Now, I've talked about fat. This is actually a tissue. I love fat. I just think it's the most interesting fat. Now, I need to preface that by saying that I'm also very much in belief that people should exercise. And I think that the human animal was built and evolved to exercise, so fat was what you needed between meals so that you had a reserve, and I think that it's a wonderful tissue. It's just that if you sit all day, it works against you. So the thing that's interesting about fat, as I mentioned, males put their fat in this intra-abdominal area, which is the very first thing when you want to exercise is you release fat from that intra-abdominal area. That's the first lipolytic action. And so you've got your ready source for kind of slow, moderate activity. If you're going to really sprint, then you're going to use a different kind of metabolism. You're going to use carbohydrates. But for most of our activity, we burn fat. For females, we really need to have some reserve, especially if we're starving, and we need to reserve something if we're going to have a baby and nurse that baby. And it actually turns out that sex hormones play a huge role in putting that fat down, and as we nurse, that fat is then released. So there are very different stimuli on how this particular fat works. And when people tell me that they're studying fat tissue, I want to know, where did it come from? Because every kind of fat we have is very different, and they are hormonally affected. Now, if I start to give this male estrogen, he may very well start to put some fat on his hips and his thighs. That's something we know the hormones will do that. So hormones do put more subcutaneous fat on a person, male or female, but generally females are the ones that have it. And this lipase, I used to study it, so you just have to know adipose tissue lipoprotein lipase. It's very interesting, but you don't have to know anything more than that. On the contrast, testosterone actually decreases body fat and increases muscle mass. So these things work. One is anabolic, the testosterone, the other is catabolic, the estrogen. So they're very different in terms of what kind of tissue we're going to actually be depositing as we get excess calories. Now this has gone awry here. This is actually anabolic steroids, but the point I want to make is males do put on muscle much more easily, and given testosterone challenge or anabolic steroids, they're going to put on a lot more muscle than a female who might be using those hormones as well. So we definitely have very different propensity to put on muscle depending on our sex. Now, I've gone a long way, and I haven't even told you about sex and gender, so the time has come. The reason that I insisted that we add sex to the title is that this really is the biology. So sex is used as a classification, generally male or female, that relates to your reproductive organs and the functions that derive from the chromosomes. So most of what I've told you so far would be sex. Gender is really something that's in studies of humans. Now, you can see lots of articles where they talk about gender differences and they're talking about a rat. But the rat, the deal with gender is that this is really your self-representation. So when we talked about the intersex, or we talked about the androgen insensitivity, where you look like a female, but you might not really have all the normal female organs, that person thinks that she's a female. And we do some work with transgender. I actually teach a class on sex differences, and we usually bring some transgender individuals in to hear why they think that they really were a man, but they look like a woman, or the other way around. And this is really gender. You basically can decide this. Now, another use of gender that I'm just going to mention briefly is gendered medicine, which is a concept that Londa Schiebinger, who's the director of the Clayman Institute on Research, has really been bringing to my attention that something about gendered medicine is that because a physician believes women have certain diseases and men have certain diseases, they may treat them differently. And this is something that causes us a lot of problems in heart disease. Many physicians don't realize that women have different symptoms and signs for heart disease. We'll talk about it again as we go on. And they basically just blow off the fact that this woman is having a heart attack. Now, we actually are pretty good here at Stanford. We have Jennifer Tremmel, who's got a whole clinic on women's cardiovascular health. And I think that Stanford has been well educated, but it's not true across the board. And I can tell you it's not true across the emergency system. If a woman calls 911, they've got very good data. The ambulance takes longer to get there than if a man calls 911. If she arrives in the emergency room, it takes longer to get her in and get her cath than if it's a man. So we have a lot of things that happen differently to women and men, not because of biological differences, but because we have a different idea of what they may have. So this is gendered medicine, and I'm going to give you another example as we proceed. Now, as we move on, what I'd like to do is just quickly mention that I'm going to do sex differences in health and disease in the USA, because it's a very different story when we start to look globally. And to just give you a quick sense, when we talk about the USA and we talk about Australia and Europe, we're talking about countries that have a life expectancy of 75 and over, regardless of their sex. Whereas we can have countries where we're really talking about a life expectancy that's less than 50. This is largely because when we talk about life expectancy, we do include those first 5 years, and if you don't make it out of year 5, which those very same countries that have low life expectancy also have a huge infant mortality and mortality. So we're not going to talk about that. I will make the point that when we look at these countries, we can talk about different kinds of diseases. So group 1 is communicable, maternal, and nutritional conditions. We really have done a great job in this country of reducing infectious diseases and communicable diseases and reducing maternal death. But you can see some countries, this is really a big problem, and of course there would be a sex difference in that. Group 2 is a group that we spend a lot more of our time on here at Stanford, which are the non-communicable diseases or the chronic diseases. And then group 3 is injuries. And I will point out that with injuries, it doesn't seem to matter what area of the world we're coming from, males have a much higher % of deaths from injuries than do females. And I don't know if that's a biological problem or what it is, but it's a major issue. The other one that I think is obvious is maternal death. I've already made the point that if you can't get the baby out of the pelvis, in some countries you're in trouble. Now in this country, we may be a little bit too quick to go to C-section, and then we have a lot of controversies about what do you do with a second birth. But it is the case that when we look at the deaths of mothers per 100,000 births, you can see huge death rates in these African countries. And when we get to the United States, in this particular data set it was 10, it's actually climbed to 13, and I can just show you that our mortality rate in the US was really quite high in the 1900s. Very nice drop. We actually are going up a little bit right now, and there's a big mystery, so that's another area that we don't have time to talk about. Norway actually has a very low maternal death rate. They also have a really high home birth rate, which is quite interesting because that's another one of our many controversies about hospitals, which 99% of US births are in a hospital. At any rate, to jump the gun, I'm just going to focus on developed countries, and I'll make the point that if we match up these developed countries with the females on one side and the males on the other, you're going to see in every single one of these countries a much longer life expectancy for the female relative to the male. Now, the US is not leading the life expectancy here. You can see Japan is actually doing better. Now, these data are actually 1995. I did stick in the 2004 data for the US so that you can see that we've improved in our life expectancy. Oh, that goes up there, 72. We've improved in our life expectancy, but that's true in both sexes, and we still have this sex difference in life expectancy. And there's a lot of interest in that issue. I will make the point that when I start showing data like this, so population data suffer the fact that everybody's in the pot, and it's not all the same if we look in different ethnic groups. So for instance, in the US, when we look at black men, I'm sorry, this didn't quite come out right. Yeah, black men, you see that they have a much lower life expectancy than do white men, and white men have a lower expectancy than white women. So there are differences in the ethnic groups that we don't have time to go into. Now, this is at birth in 1987 and at birth in 2004, so you can see that we've all improved, all ethnic groups, all sexes. This is if you are any of these ages. What is your life, how many more years do you expect? So if you can make it to that age, the game starts over again. So you get some places. If you can make it to 100, then people are a lot more similar than if you don't, in terms of only having 2 or 3 years left. Okay, so when we talk about these causes of death, again, this is everybody thrown in together, not by age, and I'll try and get you through all of these age groups in a moment, but I want to make the point, this is percent of deaths, and here's the total number of deaths. So the first thing that you'll notice is that when we talk about heart disease, I'm going to show you that at any given age, men are more likely to have a heart attack and die of heart disease than men. But when all is said and done, because women do live longer, we basically match them in the end. So the leading cause of death in women is heart disease, and it basically takes out as many women as it does men, percentage-wise. So the percent's quite similar. The next category is all cancer put together, which is actually less than heart disease. That said, I did break out the top 3 cancers. So in men, we'll use the bottom panel first. Lung cancer, prostate cancer, colorectal cancer. Females, lung cancer's the first cause of death for cancer, breast cancer, colorectal cancer. Now, men actually have accidents, more accidents than they have prostate cancer. And women actually have more deaths from Alzheimer's disease than they do breast cancer. So there's a lot of misconceptions about what are leading causes of cancer or cause of death. But this is, again, when you put it all together. If you live long enough, you're probably going to end up dying from heart disease. Question?
Is there any account for why the stroke rate and the Alzheimer's rate are higher in women?
Probably because they live longer. So that's the one reason. But we actually do have evidence now that Alzheimer's disease seems to be female predominant anyway, even if you age match them. So there does seem to be a predisposition relative to men in women for Alzheimer's disease. But the fact that they live longer, if we live long enough, our risk of Alzheimer's disease goes up quite a bit. So the life expectancy issue does come with age-related problems. Okay, so let's go through the life stages now rather quickly. We've already talked about prenatal development and sexual differentiation. I'm going to give you a few pediatric examples. There's clearly not enough time to do every disease you have. You've had 3 quarters to do that. So we're going to look at a little bit. We've already talked a bit about puberty and the fact that some of these diseases, I'll just point out, vary with a menstrual cycle. Some of the immune issues really go up and down with a menstrual cycle, so we know they are hormonally influenced. When we get to young adults, sexual activity is a big issue. We'll talk about that. I teach Stanford students, so that's what they're mostly interested in. Middle age, pregnancy and postpartum, it actually can happen in younger ages too. We'll touch on menopause and we'll do a few geriatrics. So this is really examples of sex differences. It can't be comprehensive. But what I like to do when I pull that out and put you through this is kind of just loosely fit it to decades so that we can look at the data a bit. And so when we talk about puberty, will be about 12 years of age for girls, about 14 for boys. When we get into the 20 to 39, we're in the active reproductive phase. So we've got menstrual cycle changes, we have pregnancy, we have postpartum issues. Men, we have reproductive years. For women, we start to go through changes that eventually result in menopause. And men, we have reproductive years. 60 to 79, we are postmenopausal. And men, there's a question, is there an andropause? So I'm going to try and look at that question, just a touch on that. And then we get into, I really should change this to older age, but because as I get closer over there, I feel like that has to be like another phase, right? It can't be older. But at any rate, when we look at this, a point that I want to make is men are disappearing from the population at a much higher rate in each of these categories. So although the numbers aren't great, 1% of girls don't make it to age 1, 1.4% of boys. 0.7% of boys or girls die before 20, twice as many, double percent. When we get to 20 to 29, we see again, we basically are losing men. We're still losing more men. We start to get closer in the 60s, but by the time we get out to 80, we still have more than 50% of the women who were born, and we're only down to about a third of the men. So when we start to talk about diseases of aging, many of the things that we think of as sex differences have to take into account that we've got the hardy guys out there, and then we still have half of the females. And so it's really hard to say what's a physiological difference. I mean, the clinical relationship is still important. This person is sick, whatever. But we really have been slowly getting ourselves to a survivor pool of 80-plus-year-old men relative to women. Women, we can start to get closer to that, about 90. So to just kind of quickly go through this, if we just look at causes of death in children, this is kind of too big of a lump sum. It would be better if I broke it into pre and post pubertal. But the number one cause of death, there's not many deaths, but the number one cause is accidents. And then we actually do have total cancers showing up in girls, whereas for boys, the next one is assault and homicide. It does show up with girls. Suicide, it does show up with girls. The cancers we've mentioned do show up. So some of these things are kind of the same, and heart disease is already starting to take a few. When we actually look at this accident issue, it's quite interesting. This is actually deaths in numbers. So this is the number of boys that are dying from accidents relative to girls. And somebody asked me, why is this peak at 30 to 45? And I really have to go research that. I don't actually know why all of a sudden in our middle age crisis we start dying in accidents again. But at any rate, and I'll let you guess, we can actually look this up, and I should have before I came here. But at any rate, you can see that out here, it's really just a matter of the men are, we don't have many of them left, and so it's the females. And if we actually match this by rate, we see that in every one of these younger age groups, we have this male higher rate of men. This is actually who's coming into the emergency room relative to girls. But when we get out into the 65 plus, the rates are pretty similar. Okay, so cancer deaths in this young group are pretty much the same causes. So childhood cancers don't seem to have a real strong male-female in terms of the big hitters. I will say that testicular cancer is something that hits a 20-year-old male and obviously doesn't hit a 20-year-old female. An issue that I have to bring up in any talk I give is childhood obesity. This is something that you just have to know. This is a very, very serious problem. And it's serious in whites, but it's even more serious for Mexican-American boys and African-American girls. And the reason why it's serious is that we have all these comorbidities that you heard about last week. And I just want to point this one out, which is type 2 diabetes. It's now projected that 30% of boys that were born in 2000 and 40% of girls that were born in 2000 will develop type 2 diabetes. This is the big problem coming down the pike that we have to get our handle on. So that's maybe a bit of a sex difference. Okay, sexually transmitted diseases. Oh, I meant to fix this slide, sorry. But at any rate, you should just know the US has the highest rate in any industrialized country. We have 19 million, about 19 million per year. And women are much more likely to get these, as are youth and people of color. Now, in the case of women, this relates to our anatomy. It's a lot easier to pass it from a man to a woman than the other way around. And we're vulnerable to chlamydia and gonorrhea because of changes that happen during puberty in the cervix. When we talk about pelvic inflammatory disease, there's about 1 million women per year that have this. There may be no signs or symptoms. It can go undetected. This is true in boys and girls. But there are more serious consequences for women than there are for men. And this is infertility, tubal pregnancies, chronic pain, and cervical cancer. And pregnant women with STDs are at greater risk for miscarriage, premature delivery. So these are issues that have some sexual differences or sex differences. I think most of you are very aware that we've kind of struck a hit here with finding a virus that actually causes cancer, cervical cancer, and that we know that there's the top 2 types that cause this changes in the cervical squamous cells is HPV 16 and 18. It's very common in women that are 18 to 30 years of age. Now, what you should know is that our normal immune system fights this and clears it for most people. So most of us basically are able to take care of this ourselves, but there's a small percent of girls who that doesn't happen for. And so there is this recommendation. There's a lot of controversy about that. So just to let you know, this area is full of controversy. But the speculation is that if we could vaccinate girls at age 11, we could eliminate 70% of the cervical cancer in the US. So this is a young person's issue. Moving on to the next group, we still have accidents as a leading cause of death. In the case of men, suicide, homicide are the next 2. These are particularly taking out the black men. So when we talk about the life expectancy for African American, this is an SES issue. Heart disease is already showing up. And you can see that one that I want to point out is breast cancer. So we have total cancers showing up in men, but we don't have one cancer that's popping up, whereas we already have breast cancer in the 20 to 39 group. And if we actually pull that out and look at cancer a little bit more, you see that the top 5 cancers now look different in boys and girls. So now we have breast cancer and cervical cancer, whereas in boys we're still with leukemia, brain, colorectal cancer. We also have the non-Hodgkin's lymphoma and lung and bronchus cancer. So we're getting a male cancer showing up. So the cancers start to look different now in this age group. I'm not going to take you through the immune system. Obviously, you had a whole lecture on that. But just to make 2 quick points, when we talk about B cells, these are going to be making the antibodies. And T cells are going to activate the B cells, and they're going to attack a pathogen that has affected you. I won't go into the rest of this, but what I want you to know is that this is another sex difference. It turns out that women have a more robust immune response. They have higher levels of proteins and reactions that we basically designate as demonstrating a stronger immune system. So IgM and CD4, these cell counts are considered evidence that there's a stronger immune reaction. They show a stronger humoral and cell-mediated responses to vaccination with a variety of antigens. And they have this mount a heightened thymus 1 immunity to immunization from antigens. And so basically, some of this may relate to autoimmune diseases. And I think you had a whole lecture on autoimmune. But I want to just take it a little step further, make the point that when we talk about autoimmune disease, we kind of have 2 kinds of autoimmune disease. We have organ-specific and non-organ-specific. You've probably heard of many of these. And this is the whole spectrum going from the organ to the non-organ. So there's a long list of autoimmune diseases. But to just highlight a few in the short time I have, what you can see is there's sex differences. So this is the percent of women relative to men that have Sjogren's syndrome, that have systemic lupus, erythemaides, thyroid disease, scleroderma. And actually, I put a little note here about scleroderma. I'm going to show you in a minute some of the hormone reasons that we may have differences in some of these immune response. But there's a very interesting phenomenon that came along that was identified called microchimerism in a disease called scleroderma, which is something where your skin gets really taut, and I won't go into all of the details. But they actually, in this particular lab, they found that these women had a really high percent of fetal stem cells circulating in their blood that was from their male offspring. Now, it could have been from the female offspring too, but they don't have a test to look for that. They have a test to look for a Y in an XX person. And so what they learned from that is that it's actually the case that when you're pregnant, there are stem cells that the embryo is making that pass out of the placenta into the mother's circulation and take up residence there. And they actually found that these lingered for at least 30 years. And so one of the issues is, in that women do have this foreign body on board, we have the ability, we have basically exposure to foreign DNA, and we basically may be responding and developing some of our autoimmune and some of our immune system response. So these are kind of hypotheses. We don't have them completely worked out, but scleroderma is the one where we have seen this microchimerism. Many people got excited and thought this was going to explain everything, like all the others, and it didn't. So nothing in science works that nicely, but it works very nicely in other ways, I guess. At any rate, there are a number of others. You can see here males slowly. We get to the point where with type 2 or type 1 diabetes, which is an autoimmune disease, it's pretty similar between males and females. Now, this could go on. There are a couple that are male predominant. Ankylosing spondylitis is one where you get this kind of fusion of your vertebral column, and so you become very stiff, and that starts to hit people when they're in their late 20s and 30s. But for the most part, autoimmune diseases, about 80 to 90% of them are females instead of males. So that's a big sex difference. And this is just showing you a schematic of the ones that kind of hit in our reproductive years versus the one that hits in our postmenopausal phase. And there is some evidence that hormones are influencing this, so that when we talk about the B being much greater than the T cell immunity, estrogen stimulates the B cell autoimmunity, and then when estrogens fall, a lot of times these regress. And so there is some evidence that hormones play a role. And in contrast, when we talk about T being more important than the B cells, these actually become much more prevalent in older age. So hormones may play a role. It's certainly not the whole story. Nothing is just one simple story. Rheumatoid arthritis is another one that's much more common in women than in men. And this one I want to mention just because it is the case that multiple sclerosis is more common in women, and I wish this was a woman diagram. Sorry about that. It was the case that in the beginning of the century, well, 1900s, the ratio was 1 to 1. And then in about 50 years, it was 1 to 2, and then it kept increasing, and now it's 1 to 4. So we don't really understand why we're getting this sex difference. But the reason I wanted to show you this one is there's another condition that is 9 to 1 women to men called fibromyalgia that people haven't been able to figure out what is this. It's something where a woman is in pain, and a man, the 1 out of 10 men, or 1 out of 10 people. They have all of these problems, and they weren't able to find it. They were basically saying it's in your head. And so that was something that women had to go through, feeling like I'm suffering all the time, but it's in my head. They have now actually found a cell in the brain that releases cytokines that basically seem to be responsible. And in the last 3 years, they've come up with some medications. But the reason I show it is that these are actually very similar in terms of their symptoms. And so this is a place where the belief is that this might be an autoimmune disease, and we just need to do more work on it. Speaking of pain, one of the common misperceptions is that women can handle more pain than men. And it turns out, believe it or not to be true. And so people always think, well, but women have to give birth, and that has to be the most painful thing that ever was. But, you know, now we're giving birth to maybe 3 or 4. It's true that we used to be giving birth to 12, and I don't know how many Franklin had, but some people have lots of births, but it's still a rather short period of your life. And when you actually look at the pain issue, it turns out that women have lower pain thresholds. They respond to stimuli, and that's true of cold, heat, cold, electrical shock, chemical shock. So there's some very interesting work going on here at Stanford in the pain clinic where, and it probably relates to sex differences in opioid receptors and how we function with opioids. But just to show you that there's a long list of pain-related problems that females exceed males in by a long shot, in addition to just these sensory things that we've talked about. So there's a lot of medical conditions that relate to it. And there are a few for men as well. I don't have time to go through all of these. One that's very typical of women is Raynaud's disease, which is a problem that probably related to peripheral artery disease, but not completely. That doesn't solve the whole problem. If you put your hand into a cold refrigerator, you can basically become frostbitten. And this is rare in men and something that women have. So we have a lot of sex differences, and we have a lot of explaining to do to figure out why do we have all of these differences, in my opinion. Okay, so another one is baldness. We have this idea that men are bald and women aren't. There's actually a male pattern baldness and a female pattern baldness. It's called androgenic alopecia. It's an autosomal dominant trait. 30% of white men by the age of 30 have some of this male pattern baldness, 50% of white men by age 50, and whites are 4 times more likely than blacks. So it's kind of interesting that the current fashion is blacks shave their heads and whites don't, but at any rate, I guess they don't have to. At any rate, so the other thing is female pattern balding is also androgenic alopecia. There's slight difference. I put patho here because I don't know that we should call it a pathophysiology. It sounds like there's something wrong with it, and it's pretty normal if 50% of people have it. So I'm a little reluctant to call it pathophysiology, but we do understand the physiology of this, that basically the hair follicles become miniaturized. Instead of being big ones, they become small ones. And I won't go into the different phases of how hair works, but to kind of just move to the next point, it's really site-specific action of androgens. So we know the androgens play a big role in pubic and axillary, chest and beard hair. And so when we talk about axillary, that's underarm hair, that's true for girls as well. If you don't have DHT, you don't end up with underarm hair. So those individuals that we talked about that lack the 5-alpha reductase don't have underarm hair, as well as some of the other things. And they're not going to get a beard. When we talk about scalp, we're talking about the terminal or the coarse hair. And for women, we have adrenal androgens that can cause this problem. 5-alpha reductase is converted from testosterone DHT, so that's kind of the real issue there. And I won't show you the different pictures, but what's really interesting is that even though both sexes can go bald, the pattern is very different. And that I don't understand yet. I'm trying to understand why is it that we have this male pattern, and female, they kind of lose their hair all over. They don't have particular kinds of bald spots. So there is still a sex difference even when we're talking about the hormones that are playing the role. To move on, when we get into our middle ages, and this is, I call this early middle age, and we'll soon get to look at late middle age, but this is early middle age. So again, not very many of the deaths are occurring. 2.4% of all female deaths before the age of 60, 5.4% of males, in addition to the ones that we've had before, but we're slowly adding to them. The point here is that when we look at women, total cancer exceeds heart disease, but no individual cancer does. So here's lung cancer already taking more lives than breast cancer. It's a deadlier cancer. And here's colorectal cancer. In the case of males, it's pretty even, heart disease with all cancers put together. Accidents, still there, and here's our lung cancer. And so we don't actually, and suicide, we don't have we don't have prostate cancer showing up just yet. So
the difference between lower respiratory and upper respiratory conditions, people were dying of lower respiratory?
yeah, I don't actually know that people die of upper respiratory very often. So lower respiratory is kind of in your lower lungs. It's deeper in there as opposed to up in the bronchus. Is that? Okay, so in terms of the probability of developing cancers, I'm just going to point out a couple things on this busy table, and you get all the slides so you can study them at your leisure. But I'll make the point that 1 in 2 men will die of cancer eventually in the course of his lifetime. Now, the one that's, this isn't dying, I'm sorry, this is getting cancer. This is not dying of cancer. This is the incidence. So 1 in 2 men will get cancer. To a large extent, this is prostate cancer. It's actually the case that many men have prostate cancer that don't know they have prostate cancer. They've done these autopsy studies of men who have died from other reasons, and they've done autopsies, and they see that they have prostate cancer. But it didn't cause them any problems. And so this is actually part of the cancer debate. You'll probably hear more about it next week is, do we need to be so aggressive if it's not really going to cause symptoms? And I won't go into that at this point, but to make the point that it's very rare in young men and clearly increases as we age. Similarly, melanoma of the skin increases as we age. So you can take a look. Age is clearly a big risk factor for everything. Now, when we talk about cancer incidence, I will point out that when we look at male-female differences, what you're going to see, oh, I guess I forgot to put the females in there. Did I not show you females? Oh, yeah. Okay, I'm sorry. I jumped past it. So in the case of females, 1 in 3 women will get cancer in the course of her lifetime. Breast cancer is the one that's going to be the most common. Remember, prostate was 1 in 6, so this is 1 in 8. And this is because if we live long enough, this is going to eventually happen. Now, to just jump back to where I was, I want to make the case that when we look at incidence, it doesn't matter what ethnic group we look at in the United States. Males have more cancer, this is total cancers, than females. When we go and look at the kinds of cancers, we can look at, this is looking again at cases. So the most common cancer in males is the prostate cancer. I did highlight urinary bladder because it's much more common in men than in females, so it's maybe a male cancer. It has reasons for that. Breast cancer is the leading female cancer, so these are very different between men and women. Uterine and ovarian, obviously, some of those. Lung cancer is really pretty common in both men and women, as is colorectal cancer. Now, to move on to deaths, the exact same story. It doesn't matter what ethnic group you look at in the United States, males die from cancer at a higher rate than females do. And if we look at the kinds of cancers that we're dying from, lung cancer is pretty much responsible. This is the percent of cancer deaths, so just to qualify that. It's pretty similar. Prostate cancer is actually not causing as many deaths percentage-wise as breast. Here you see ovarian, here you see the uterine corpus, and here you see the bladder. So there are some differences between men and women in the kinds of cancers we get, but then again, as I mentioned, more men. Now, lung cancer is a big part of the male-female difference. Question?
Could that have to do with early detection and like sort of social differences between men and women getting screened or?
So her question is, could this be early detection, that there's a difference between women getting screened relative to men? Those are, in terms of the incidence, I think that's a possible explanation. It's not the only explanation. In terms of death, I guess even their treatment could be a possible explanation. And this is again a case where gendered medicine is part of this story as well. So, who's going to get screened, who's going to be encouraged to be screened, but that's an excellent question. Right. Yeah, I don't have time to go into why all these sex differences exist. Okay, so a few more. Coronary heart disease. This is one, as I mentioned, but when we adjust this by age, we see that men get heart disease at a higher rate than females do. Now, this is very much an age issue. I can just tell you that this difference caused an entire area of my research because people were basically saying women are protected against heart disease because they have estrogen, and when they go through menopause, they lose their estrogen and they lose their protection. So that's the story that we used to live with. And so I actually tried to figure out, is that true? Or is it just that men start getting heart disease at earlier ages for all kinds of other reasons, including where they put their fat and all kinds of other things? And so this is actually a logarithmic scale of heart disease putting on top of that menopause, and the data are like compiled from lots of population studies. And what you see is no evidence whatsoever that menopause is changing the course of heart disease. On the other hand, with breast cancer, even though I mentioned the fact that the older we get, the more likely we're going to get breast cancer, this is a huge curve. the slope of this, when you have that estrogen, your own estrogen on board, that influence on breast cancer is remarkable. Go through menopause, and you actually see that menopause is somewhat protective, or is protective, I think. So I don't have time to take you through all of menopause, but basically we do talk about menopause now as a very long process. It's no longer the case where you jump off a cliff and, you know, today I'm premenopausal, tomorrow I'm postmenopausal. We now recognize that this is a slow, gradual change that goes along with age. And this is something where it's very different from men and women. It's something that women will remember when they went through their menopause. You start to have irregular menstrual cycles, you have hot flushes and night sweats. Now, men actually do experience hot flushes and night sweats when they're taking antigonadal hormones for treating prostate cancer. So there are men who know what hot flushes are, and they don't like them either. At any rate, when we talk about there's other things that happen when you don't have your estrogen on board. There's a transitory accelerated bone loss. Now, when we talk about natural menopause, this basically is if you still have your uterus and can check on your bleeding, you've stopped bleeding for 12 months, and that's considered a natural menopause. If you take out the ovaries, you can have menopause any age. So that's surgical menopause. Now, for most women, you do have some estrogen on board. You make some estrogen in your adrenal glands, as do men. And testosterone can be converted to estrogens in fat tissue. So it actually is the case that obese men and women have higher estrogens, which is one reason that obese men start to develop breasts. But at any rate, most women don't report symptoms after they've been through their 3 to 5 years. I have a curve that shows that some women continue having them for 40 years, so it's not true that we're all going to just be so lucky. But at any rate, most women will have 3 years of hot flushes. Some will continue. In Sweden, they actually have these great databases, and they show that 9% of women age 70 and over still have hot flushes. But now we have gradual bone loss, and so I want to talk about that. I will tell you that even though obese women have higher estrogen levels, it turns out they have worse hot flushes. And we're actually studying that now in biology with Craig Heller, trying to understand, is this because we're insulating our bodies and basically we can't dissipate the heat if we're carrying too much fat. So this is something that we're trying to understand. I'll just quickly mention the Women's Health Initiative because it was brought up. This was really a study. Menopause really is very nicely treated with estrogen or just wait it out. If you can wait it out, that's probably your best bet, but not all women can. We never say that you shouldn't use estrogen to take care of menopause, but we had this kind of epidemic, if you will, or a problem in the medical community where the idea was that women were protected against heart disease by estrogen, so we should put them on estrogen to prevent heart disease. And this was really happening at really high rates. So we really had millions of women who did not have hot flushes being put on hormones to prevent heart disease. And so we actually studied this in the Women's Health Initiative. We had a huge study, really 2 trials, one of women with a uterus who were taking estrogen and a progestin. The progestin protects the uterus against endometrial cancer, which is stimulated by estrogen. And then if you had a hysterectomy, just estrogen. And this is really a schematic. I don't have time to take you through all the data, and you don't want to see that anyway. But we had stopping rules based on all the epidemiology that we had available to us. So we had the strong belief that estrogen would protect you against heart disease. We were worried about breast cancer. We really didn't know about stroke. It was kind of bouncing around. It's not so common that we had as great population data as we'd like. We did expect blood clots mostly from the high-dose oral contraceptive literature and from a study that they did in men back in the 70s where they gave them 5 times the dose of estrogen that we ever would give a woman. And they had blood clots and heart attacks, and they didn't have a good time. And they developed breasts, and that wasn't very good either. And then we did expect benefits to bone. And the deal was we would stop the trial if breast cancer happened and the overall picture was harm, but we wouldn't stop it if breast cancer happened and the overall picture was benefit. And vice versa. If we had a benefit, we wouldn't stop it unless the overall picture was benefit. So to just cut to the chase, in the case of the estrogen and progestin trial, and this is something the media still doesn't have worked out, these trials came up with different results. The estrogen and progestin trial done in women with a uterus, basically the first thing that happened was we had our preset cut point for breast cancer was hit, And that would not have stopped the trial because by that time, we already had fewer hip fractures and fewer colorectal cancers, that this would have basically teared it out to even. But the hypothesis was wrong, and our public prevention rules were wrong. We had more heart attacks, not fewer, more strokes, and the blood clots. So the overall picture was clearly one of harm. And we sent out huge alerts to everybody that estrogen and progestin was not something we should be prescribing to prevent chronic diseases in older women. Now, this actually was a huge story. Some of you might remember it. First it was about hormones, and then everybody started talking about menopause. And what we were trying to explain to them is, well, the hormone story we studied was about whether you give these hormones to older women to prevent diseases of aging. And it wasn't about menopause, which it turned out we didn't know very much about because we weren't studying it. It wasn't a life-threatening problem. It was just a quality of life issue for women. So this was a case where we recognized we really need to understand this physiology. And I think in understanding this physiology, we're learning more about the physiology of men, and especially temperature regulation and some of the other issues. But one of the things that happened was women came off these hormones and doctors stopped prescribing these hormones at a huge rate. And the interesting thing was 2 years or 5 years later, we actually saw in the registry, the SEER registry is this giant surveillance system for looking at cancer, we actually saw breast cancers drop in the whole population of the United States. And this was the estrogen positive breast cancers. And this is actually quite a remarkable drop. Nothing that I've ever done in prevention could have done this. And so this was not even what we set out to do, but it was a huge population benefit to just basically stop that particular practice. Now that said, that's dropping hormones across the country. We had not really even published the estrogen-only trial before women start coming off their pills. And in that case, we did not see increased breast cancer, and we did not see increased heart disease. So in the estrogen-only cancer, we did see higher strokes, and we also saw the benefit to bone. And so this was really a more neutral picture. Now, I don't know how it really applies to everybody. I will tell you that in this trial, we had a really high % of women who were obese. And so I don't know how it applies to thin women. We do have data on breast cancer, for instance, that thin women have increased risk of breast cancer when they go on estrogen, and overweight women don't. So it's a complicated story, but the important thing is it's a different story than the estrogen and progestin trial. So when we talk about how this trials are similar and how they're different, they were similar in showing no benefit to heart disease, and then actually increased harm in the one case. More strokes, more blood clots, but benefit to bone. It's really very good for bone, but we have alternatives to bone that I don't have time to tell you about. The breast cancer results were different. The global index is an overall balance, so the balance was in harm for one trial and balance for the other. Now, osteoporosis is another important issue. This is one that's called a woman's disease. So back to gendered medicine. Very few physicians check bone density on older men. 1 out of 3 hip fractures is in a man. So we have this problem that we don't focus on something that isn't a man's disease, even though men get it. So when we talk about osteoporosis, this is a really strong bone. Here's an osteoporotic bone. You can see not only is it a lot thinner, but there are fractures. There's just no engineering integrity there. There's no structural integrity. When we look at the risk factors, these all come from studies of women, with the exception of the primary secondary hypogonadism in men, where they just have really low testosterone, and it's really testosterone being converted to estrogen. We don't know the risk factors for men. We have not studied them very well. I will show you that when we look at bone, men are losing bone just as women are, but they're higher to start with. Women have this accelerated drop at menopause, and then they resume. So they hit a fracture threshold about 10 years earlier than men. So it's the reverse of heart disease. Women are about 10 years behind men, and men are about 10 years behind women. Yes?
There is a test of osteoporosis taking place right now. I'm a part of it. It's being the VA in Palo Alto and Stanford as well.
Right, I'm trying to get the slide to come up because I don't have your picture here, but it's called The Study of Osteoporotic Fractures in Men. Mr. Oz, I'm the principal investigator. You probably get letters from me. So this is a study that This is a study that has 6,000 men who are 65 and over. One of our participants actually turned 100 and is still going strong. He just came in recently. In addition to this study, so we are doing this. We're trying to correct this problem. This is kind of one of my missions, is be sure that we study men when we need to study men. And we actually have a really interesting sleep study. I don't know if you're in that one too, but this is how we put the men to bed. We basically go to their homes and we wire them up completely, and we get all this information, looking for we're trying to figure out what causes heart disease in these men. And I will point out, when we talk about sleep, women complain a lot about sleep problems with menopause, and I think it's absolutely true, but I think it's also worth noting that at every age, women have more sleep problems than do men. And so this is another place where we have kind of a misconception. And we're coming near the end. We're going to talk a little bit about aging in men. So in the case of men, there is a decrease in hormone production. There is some sexual problems. The hair, the graying is not related to the androgens, by the way, so it's not part of the alopecia issue. We've already talked about the baldness. Voice, is actually some changes in the vocal cords, so there is a slight elevation. We're not really sure about body odor and acne, which are things that start at puberty, what happens to them. We haven't studied it very well. But an area that we're really interested in, that we hope to study in Mr. Oss, is sarcopenia, which is a loss of muscle mass and an increased fat where there used to be muscle. And you probably heard about that last week. I hope you did. But at any rate, it seems to be that stem cells that should be replacing your muscle start to make fat instead of muscle. And we're very interested in that phenomenon. Hopefully, I'll come back in a few years and tell you about that. In terms of bone density, we do see a decrease in bone density with time. And I really, I'll just for the sake of completeness, point out that by the time we get into the 60 to 79, we have cancers exceeding all other causes of death, but heart disease is exceeding any individual cancer in this particular age group. There's something not quite right on that slide. I'm going to just move because I'm a little worried about that. I want to focus back on men. So with men, there is this decrease of testosterone. And it's not the case that they just stay high all their lives. The older men get, the lower their testosterone. And there is a point where we start to talk about hypogonadal levels. When we talk about that, the medical problem is not just low testosterone. It's if you also have symptoms that suggest that your body's not responding, that it doesn't have testosterone responses. So this is decreased libido, sense of vitality. We've mentioned the erectile dysfunction, reduced bone mass, and bone density, and anemia. So this is an interesting thing. Testosterone actually increases blood count, and that's a big sex differences are anemic levels. So you can see that about 20% of men aged 60 and over and about 30 to 40% of men 80 and over have this. There is a big trial underway that unfortunately Stanford didn't get. We almost got it, looking at testosterone, very much like the Women's Health Initiative, but smaller pieces, trying to understand, does testosterone help aging men? And this was actually something, I wanted to just quickly mention, one of the concerns is prostate cancer, but I've always made this interesting observation that testosterone levels are going down when prostate cancer is going up. So we don't really have very good cause and effect data on that particular phenomenon. And the Institute of Medicine did a report where they really weren't very convinced that that was a problem. And so this is the areas of study now that the Institute of Medicine has felt we really need to do with men and testosterone. Looking at body composition and strength, physical function, cognitive function, mood depression, sexual function, quality of life, cardiovascular, blood, prostate, and other multiple outcomes. Question?
When you're doing testosterone replacement in men because of some method that says it needs it, I assume you're giving them real testosterone with the molecule looks just like a human testosterone. You're not giving them something extracted from horses?
Yeah, so her illusion, I think I had it up there, is that the most common estrogen that we use is conjugated equine estrogen, which equine is horse, so it is extracted from horses. There are real estrogens available for women. The case of testosterone, most of these are testosterone that they're doing. But the original, if you study the history was dog testes and cow ovaries and things like that. So these studies are being done with testosterone. So I think I'm at the very end now, and I just want to say that by the time we're 80 plus, remember, we still have more than 50% of women, and we have about 1/3 of the men that were ever born. Heart disease is the leading cause of death in these old people, older people. Cancer is the next altogether. Now stroke, so the question about stroke, you see that when we get into the 80 plus, we have stroke appearing in men as well as women. But we have Alzheimer's in women and we don't have it in men. So there is a sex difference that we're very interested in trying to understand. Here's lung cancer showing up in both groups and prostate cancer here. You see when we actually do it this way, we don't have breast cancer any longer in this group, in this age group, as being hitting this. It comes up very soon thereafter, so I don't want to say that it's not. It's just not one of the top 5, I think it's like 2, 4, 6. And so that's the end. That's just a whirlwind of sex differences, but I can tell you, this is a 10-week course that I give, and we just scratch the surface in each one of those classes. There are huge sex differences in diseases. There's lots of reasons: screening, detection, education, how the medical system works. We have so many avenues to look at in this issue to try and understand the sex differences. And studying sex differences in and of themselves is not so important as helping both men and women. And many of us believe that the more that we study these differences, the more we're going to get to the real basic biology in ways that we haven't really even tried to do yet. And so this is a new field. It's been going on for about a decade. There's a lot of interest in it now. And Stanford's women's health at Stanford is actually got sex differences as one of its primary missions that we're trying to study. And many of the institutes are involved in it now. Thank you. Somebody had a
Thanks so much.
question.
I think we have time for questions, so let's. You can go back and forth between the genders.
Okay. I should put a good picture on, though, huh? I'll put. That one's a good one, right?
So what was the upshot for menopausal treatment? Are you personally, and is the medical profession now saying no hormones, no bioidenticals, nothing?
Well, there's a lot of controversy in that field. So when you say the medical profession, it depends on what part of the medical profession you're in. The FDA, and I agree with them, basically say that if you can't tolerate, so we say go from moderate to severe symptoms. If you can't tolerate the symptoms, going on as low a dose as is effective for you for a shorter period of time. So that's kind of nebulous, but basically instead of 0.625 milligrams of conjugate equine estrogen, or its counterpart. So there's estradiol, there are patches, there's lots of different kinds, and that's another whole talk. You go on a dose that's about half what we used to be recommending, and you don't plan to stay on it the rest of your life. You basically go on it for maybe 2 years, come off, see how you feel. If everything is horrible again, then go back on 6 months. So basically it's kind of, there's no discouragement for using the hormones the way they were indicated by the FDA for menopause management. They still are the best game in town. In terms of bioidenticals, this is essentially the idea that you're trying to get exactly the same kind of hormones in your body or you're trying to replace hormones in your body that are like your own. I don't think the science is very good on that. So I think the hype is great, but we don't have good studies. It doesn't make a lot of sense to me that I'm going to measure my low hormones and tell me that's what I should replace. What I'd like to know is what am I missing, not what do I have. So I'm not real enthusiastic about it, and I can tell you the American College of Obstetrics and Gynecology basically feels the same. So again, it depends. When you say the medical profession, there's lots of variations on that theme.
This is a bit of
You're a woman,
back to
sorry.
the beginning of your talk, when you said that the males, when they're like newborns through age 2, are very hormonally sensitive.
What I was saying is that for the so she's trying to understand what's happening in that first 2 years of life. So as soon as you're born, there's this big LH surge that occurs, and so the fetal test, the young testes, so it's not a fetus anymore, it's now a newborn baby testes, gives off testosterone for about 6 months. And the females also have some pulsatile stuff going on. They start to secrete some estrogen from their ovaries for about 2 years. So the interesting thing is that, and then everything quiets down until puberty. So this is rather new information. I mean, it's not that new, but it's certainly, I didn't know it when I went through graduate school. So it's you know, at least 20 years.
I know somebody who refuses to give her son, her toddler, soy because she's afraid that estrogens will be introduced to him. I don't know if that's
Well, he just came out of a pregnant woman, so she says she has a friend who's afraid to give her child soy, and I don't want to get into anybody's, you know, what they want to do with their children. But just to remind you that, you know, all those boys were in a pregnant woman who had really high estrogen levels, so they were exposed to lots of estrogen just before that birth. Okay, I need to look for a man now. There you go.
What happens to a woman's health when she gets a hysterectomy, and are we doing too many of those? And what about taking out the ovaries as well as the uterus?
Yeah, so there's a lot of questions about taking out the ovaries, and it's kind of a new debate going on right now whether we should or shouldn't. So the hysterectomy is taking out the uterus. Often there's a good reason for taking out the uterus. So there's been excessive bleeding. This is particularly true with obesity. Women bleed more because they have those higher estrogen levels without progesterone. Certain ethnic groups, like African Americans, have fibroids at a much higher rate, so they have bleeding. There are multiple reasons for hysterectomy. In terms of are we doing too many, I think that things have changed a lot. It does vary a lot by state, so I think there's some states that are doing too many and others that aren't. And I don't want to really criticize without knowing why. But in terms of the ovaries, it used to be kind of a prophylactic thing. If you're in there, let's take out the ovaries so they won't get ovarian cancer, which is a very deadly cancer because it goes undetected for a long time. But the question then is, does that estrogen that those ovaries were producing have health value? And so the answer to your question is I don't really know, and we're trying to understand that now. And there's a person at UCSF, Vanessa Jacoby, who's kind of making that her career, and I'm actually mentoring her. So I hope that I will learn more as she learns more, but I don't know the answer yet. Oh, you're a man. Wait, let me get a woman, and then I'll come back to you. Okay.
Is the treatment for osteoporosis basically the same in men and women? And do you start a protocol of treatment and reevaluate and retest, or is it something that once you're on the treatment, you're on indefinitely?
Okay, so her question was, is the treatment for osteoporosis the same in women and men? And the answer is, some of the drugs have been FDA approved for men, so there's been some research done in men. But compared to what we know about women, it's really lacking. So we do have some things that we do with women that we don't have those studies for men. And let's see, the other part of the question.
Do you retest for bone density?
And do you retest for bone density along the way? I think most endocrinologists do. You know, I don't actually know what the rationale would be in that you're taking the drug, and I don't think you're going to ever get all that bone back. But I think they do some evaluation to see if you need to go into a more aggressive kind of treatment. Okay.
You mentioned scleroderma. Just wondering, are there any other pluses and minuses for pregnancy in a woman as it affects disease?
Yeah, that's a great question. So it turns out some of the autoimmune diseases actually regress when you go through pregnancy. So multiple sclerosis actually tends to get better, and it might be because of the estrogen, the high estrogens. The problem is then when you deliver and your hormones fall, then it comes back. So the pregnancy, the hormones do benefit some of the autoimmune diseases.
When you were talking about scleroderma and the other autoimmune diseases, you seem to be implying that if a woman had male children, she might be at greater risk of the more organ-specific.
Yeah, no, so I'm sorry.
What you were saying?
No, it's not, but I can see where you get that. Okay, so she asked, was I saying that male babies cause more of the autoimmune problems? Is that? For the mother, okay. So the problem is it's a test that they were doing to look for these fetal stem cells. And the test only is able to look at Y chromosomes separate from X chromosomes. So there's probably just as much problem with having an XX baby, but they can't find it in the test they have right now. So it's just a matter of getting the test where we can look for the female fetal cells as easily as we can now look at the male fetal cells. And if I say anything wrong, you correct me.
You talked about B cells and T cells, and B being more in the presence of estrogen. Is that true also for males which don't have as much estrogen?
You know, so he asked about the B cells, where I was making the point that the antibodies seem to be something that autoimmune disease that have a higher B to T are coming into those reproductive years. And he wants to know about men, and unfortunately I don't know the answer. I have to admit that I've done more women's health than I have men, but now that I'm interested in sex differences, I hope to find the answer. Do you know?
What about testosterone therapy for women?
Okay, so they do some testosterone therapy for women, mostly for libido, to increase sexual libido. That's the main purpose of it. Actually, it's the case that testosterone is converted to estrogen to take care of the bones. So you know, we used to believe that testosterone was the reason men had denser bones, but it is, but indirectly, because they're converting it to estrogen. So there isn't a good reason to use testosterone just for that purpose. But it would, I mean, if you can convert it, as long as you have the aromatase to convert it, you can convert it. Okay, woman back there.
Is there any relationship between the time one goes through puberty and the onset or incidence of age-related diseases?
It's a great question. I don't know the answer. And you know, the problem with, there's a few areas in this field that are really challenging. One is oral contraception, because they kept changing the doses. So the doses of the people that are now old enough that they're getting diseases of aging, they either never took oral contraceptives because they didn't exist, or they took really high doses. And now we're finally getting the epidemiology that we need on the next group, but they'll keep changing it. So with puberty, we have a similar kind of problem where the age of puberty is slowly going down in girls, probably because of the obesity issue, but that's kind of our best guess. We don't know for sure about that. So I don't know the answer, and I think it's going to be hard to get the, we call it cohort epidemiology, where you're following a cohort of people. Too many things change before you get to the point where you can look at the diseases of aging.
Regarding the variance in gender-based accident deaths, what are the studies showing regarding the reasons for that?
Yeah, that's what I really was negligent. I meant to look that up, because you can actually look all of this up in the CDC. You can actually go onto your computer and look up all the causes of accidents. Motor vehicles is the most common one. Drug-related is the most common one.
It's testosterone etiquette.
And people like to say it's testosterone, but I don't know if it's testosterone. I think it's all, it might be fetal testosterone, so your brain comes out like that. I don't really know. You know, our society allows boys to take risks. When you start, I actually do teach in the human biology program, and they have this great A core, B core, where the A core you learn all this sociology, and you start to realize there's all these other explanations. The B core is the biology. And so there's a lot of things that allow boys to take risks in this culture that may relate to it as well. And it might be testosterone, I don't know.
Goes along with the clicker, right?
Yeah, yeah. Actually, there are differences, and boys are good at that.
Yeah, we'll do one more.
Okay, one more.
So since we lose more men than women early on, is there a compensating factor in the birth rate between males and females? Are more men born kind of to make up for that?
You know, I knew that. If there is, it's so small that it's not going to make the difference you'd like.
Well,
or that we'd like, right?
It depends who would like it. All right, thank you very much, Marcia. That was great. So for your reading pleasure, I did look it up. Middlesex is about the alpha-5 reductase deficiency, And it's a great book if you haven't read it, because the first phase of this youngster's life was growing up as a girl, and then he got to adolescence and converted to a boy. And so I sent you a note recommending that you read it. And I'd recommend it to you as well. Yeah, so you can, this is your assignment for next week. Anyway, thank you all. See you next time.
For more, please visit us at stanford.edu.